Welcome to Decoding DX. We're a group of fourth-year medical students with a passion for education and patient care.
This episode of Decoding DX is for educational purposes only and should not be used as medical advice. Please consult your healthcare provider for any medical needs.
The opinions expressed represents those of the participants and are not of our affiliated institutions.
Thank you for joining us on Decoding DX. We keep learning so much through this experience, and we're so glad that you're learning alongside with us. Now, let's get to the episode. All right, welcome to another episode of Decoding DX. We have another abdominal pain case tonight. It'll be a pretty good discussion, and we're actually going to do a roundtable with just M3s and M4s tonight. So, Anne, let's go ahead and start with you. Tell us who you are, where you're at, and something about you that does not involve medicine.
Yeah, so I'm Anne Recker. I am an M3 down in Wichita. I was 2 and 2, so I've been down here since June, I guess. And something about me, not related to medicine, I really enjoy horseback riding and training. So still trying to do that on the weekends when I can.
Awesome. I wish I could do that. Jacob, what about you?
Hi, my name is Jacob Lutgen. I'm in M1 here in Kansas City. And outside of medical school, I enjoy watching sports and doing things outside.
Sweet. Rachel, you're up.
Hi, I'm Rachel Jenkins, third-year medical student on the Kansas City campus. Something not related to medicine is that I have a dog that we adopted earlier this summer that's been really great.
Oh, what breed?
She's a boxer mix.
Love it. Alrighty, well, let's go ahead and get started with our case. So, our chief complaint tonight is severe abdominal pain or acute abdominal pain. So we have a 21-year-old female with no known past medical history who was presenting to the emergency department for severe abdominal pain. She describes this pain as kind of periumbilical, kind of around the middle. It started about 1 hour after she ate dinner this night, and she describes it as kind of a sharp and stabbing pain that kind of comes in waves. So when it comes pretty bad, it's like an 8 out of 10, and then it'll recede to like a 4 out of 10. So given that initial first HPI, Anne, what are your initial thoughts? Oops, sorry, muted there. What's going through your head? What's the top few things on your differential?
So something kind of big, bad and ugly that I want to rule out is an ectopic pregnancy, just because she is a 21-year-old female, but also kind of normal things, appendicitis. If they'd had previous surgeries like an obstruction, but since she doesn't sound like she hasn't necessarily nausea, vomiting that came on first, maybe not that. And yeah, I guess those are my couple first thoughts.
Awesome. Those are great things. I know the ectopic pregnancy is the always rule out with a female, especially within the ED, for sure. Good thought. Jacob, anything particular that you would be asking on review of systems or looking for on physical exam?
I guess we already talked about severity and it coming in waves. So I guess maybe anything that makes it better or worse.
Yeah, for sure. That's always super helpful to figure out any relieving or exacerbating factors. Rachel, anything to add to that, either to the differential or to things that you'd be looking to ask her?
Yeah, I think I'd want to ask about changes in bowel and bladder habits, just because it could be like constipation or gas or anything like that. Also, thinking just about if she's ever experienced pain like this. And I would probably just run through kind of a full general review of systems just because we don't really have a lot of information. So kind of hit each system. Like, are you having chills or fevers, chest pain, shortness of breath, kind of hit everything just to, if there's anything else alarming, we can know about that right away.
For sure. Common things are common. It's easy to forget that at an academic center, but common things are always common. Alrighty, so a little bit more information on review of systems. Some positive review of systems include fatigue, night sweats, and then for the past 6 to 9 months, she's been having some cold intolerance with 3 to 5 soft, large volume bowel movements every day. Negative review systems pertinence include no fevers, no headache, and no vomiting. On initial physical exam, her blood pressure is 102/64. Her heart rate is 107. Her temperature is 36.9 Celsius. And not a vital sign, but calculated, her BMI is 17.5. She is a thin female lying in the hospital bed in kind of the fetal position on her side. Cardiopulm, her heart is regular in rhythm. Her lungs are clear to auscultation bilaterally. Her abdominal exam is tentative palpation in the periumbilical and the left lower quadrant. Her Murphy sign is negative. She does have a little bit of guarding, but no rebound. Her skin looks a little pale, but she doesn't have any rashes or any evidence of any lesions or bruises or anything like that. So given that extra information from the review systems and the exam, Anne, we'll start back up with you. What would you give for a problem representation for this girl? So problem representation just basically being kind of your one-liner, trying to cue up the patient in front of you as a good way to communicate, such as to your attending, what is this case? What is going on in this girl?
Yeah, so this is a 21-year-old female presenting with severe acute abdominal pain, kind of periumbilical and also left lower quadrant, who has had fatigue, night sweats, and cold intolerance, but is currently afebrile, tachycardic, and yeah, kind of pertinent.
Yeah, that's really good. I think I would add into that her low weight. I think that's definitely applicable to this presentation. Again, with the 21-year-old, it's kind of hard to tell how applicable that may or may not be to the situation, but just helps to frame it in addition to everything that you said. I think that was really good. Jacob, we'll move on to you. What type of a workup would you start in this girl if you were seeing her in the ED? So like any initial labs that you would want to order, what would be the first things that you would want to know to kind of lend some objective data to what you saw on exam?
Sure, I'd probably want a CBC, just kind of see if you're looking at an infection and if you're either blood cultures. Probably CMP to look at possible liver involvement. Look at a lactate. Guess I don't really know outside of that.
Yeah, that's a really great start. And in a lot of ways, that's the ED special, is let's just get a CBC, a CMP, a lactate, maybe some blood cultures. Maybe run them through the donut of truth on the way, which is the CT scanner. We're not quite to that point yet. I just like to talk about that in ED. Rachel, anything to add to that?
I'd probably throw in a TSH. This was some of this like fatigue and cold intolerance and stuff. I feel like TSH is another very common thing across all specialties that people get.
I love that you said that. Already just in my, year and a half of clinical training, I've seen so many cases where it's kind of an enigma and then suddenly we get a TSH and it explains everything. Kind of add to the, it could always be cancer, it could always be the thyroid. Great thought. All right, I'll give you a little bit of that data. So initial labs, her white blood cell count was 5.2. Hemoglobin was 11.5 with an MCV of 82. Her platelet count was 240. Sodium was 136. Potassium was 3.2. Her chloride was 102. Bicarb was 20. BUN was 17. Creatinine 0.9. And glucose of 94. We did get a CMP, which includes some of the liver panel. So of note, things that were normal in that liver panel include the AST, the ALT, the alk-phos, and the bili, so the main liver panel, as well as a urinalysis was normal, a lipase was normal, and a lactic acid was normal. Because of concerns for some of the things you guys mentioned, an abdominal ultrasound was ordered, and it was read as unremarkable without any evidence of acute biliary disease or other intra-abdominal pathology that was seen. So we got some extra data, maybe not the most helpful in the world, maybe yes. What do you guys think? We'll mix it up a little bit. And Rachel, we'll start with you this time.
Yeah, I mean, I feel like I am waiting for some more of the labs to come in because that was a lot of numbers at once. But I feel like most everything was normal, especially kind of the big things that we would just go for, like less concerning for infection, things like that. And especially now that the imaging, at least the one that we got, came back relatively normal, you know, some of those like more scary things we can rule out. Although I'd probably be interested in a like KUB, just because it would allow us to see some more of like that gas pattern in her bowel, which I think would be important here.
I think that's totally on point. Anne, anything to add to that?
I guess the only other lab I had a question about was like a beta HCG, if we had done that, but with her low weight, I would have been concerned about electrolyte abnormalities, and it seems like everything's mostly normal, maybe like a little borderline, but nothing so acute right now. But I think we need to worry about it. But yeah, I guess that's where I'm at.
Yeah, I totally agree. I think overall these labs are not super helpful, unfortunately. Sometimes labs can seal the deal and sometimes they tell you pretty much nothing. Yes, beta HCG was done and it was negative on the urine. So I love how persistent you're about that. That's super, super important. So Jacob, given this kind of picture, so this girl's in the emergency department. What do you think her disposition would be? And the meaning of that does she need to be admitted to the hospital? Do we watch her for a few hours? Do we send her home? And what kind of a follow-up do you think she would need?
I mean, it sounds like she's in a lot of pain. She doesn't seem very comfortable. So I guess especially with these labs, we don't really have a ton of idea about what is going on. It makes infection seem less likely. I kind of lean towards potentially staying in the hospital to try to work up what's causing all the pain. But I don't really know.
Yeah, I think one of the benefits of having kind of a busy ER is that you have some time to watch your patients. And so like in this girl, I think it'd be definitely reasonable to kind of, see how she does over a few hours. If the pain gets better, then great. Maybe she can follow up outpatient. If it gets worse or it doesn't get better, then I think you're totally right that it would warrant maybe coming into the hospital. So I will tell you guys that her pain did improve with some IV fluids and some pain meds. So she ended up being discharged from the emergency department without any major prescriptions or really without any major answers. Rachel, if you were sending this girl out of the emergency department, what would you give to her as far as return precautions? What would you tell her to watch out for to come back?
Yeah, I would definitely say like worsening pain that then is continuing to be unmanaged with like the same pain medication that she received in the emergency department. So if it was NSAIDs or something, come back if that's not working anymore and it's getting worse. If vomiting starts happening, especially if it's bloody, or if like she's no longer having any bowel movements or urination, spikes of fever, I think those would be the big things.
Yeah, I think those are really great. Any like particular big bad thing that you'd be concerned about that we maybe would miss in this girl that would happen if she went home? Like, I guess I'm asking what are the reasons that you're giving her those specific return precautions? What would you be worried about?
I guess I'm most worried about like, I don't know, some sort of like GI perforation type situation. Yeah.
Yeah, for sure. I love that. I always find that having some diagnoses in mind when I'm telling a patient about return precautions is really, for me, the best way to make sure that I cover everything. Is just kind of thinking through, what would I be really worried about happening to this patient when they leave? And then kind of running through what would I expect their symptoms to be if that were to happen, to try and give themselves an advance warning to come back before things get really bad. So I think you're totally on the ball with that.
I have a question. Do you happen to remember which pain meds you sent her home on? Because with her electrolyte abnormalities, I'm concerned about like slowed bowel movement and that sort of thing. And so I wouldn't I wouldn't want to give this patient opioids because that would slow her bowels even more. So if there was an obstruction or anything like that, that would, I'd be concerned about that getting worse. So do you remember what you guys chose to send her home on?
Yeah, so we actually sent her without any pain meds. I probably slurred through that a little bit. She did get, I think, 2 doses of fentanyl in the ED, and that helped to control her pain in the ED. But she did not require any pain meds going home. And she was actually kind of one of those patients that is a little scared of opioids. And so she really kind of, once her pain was controlled, she really asked not to be given anything more. So I think we counseled her to, if it got, moderate again, that she can try some ibuprofen, see if that helped. And then again, kind of like Rachel said, if it got really bad again, to come back in. But I love the emphasis on the common things here, guys. It's awesome. The common things are common: constipation, all those types of things. And really any sort of GI tract pathology can be worsened by opioids. So definitely something to keep in mind. It's important to treat our patients' pain, but it's also important to be careful that we don't cause more harm by giving them medications. So fast forward a few weeks, and she now presents to an outpatient GI follow-up. So we did go ahead and put in that referral from the emergency department for her to see GI as an outpatient, largely because she'd been having kind of these like 6 to 9 months of these large bowel movements, and now she was having this acute pain. So there was some concern, kind of like all you guys were saying, that maybe there's some GI stuff going on, but just not quite enough to put her in the hospital. So she presented to GI clinic, and it was a much more arduous process than this, but I'm going to give you some of the high points of the tests that were ordered and what were some of the findings. So some pertinent normal tests included a celiac panel was normal, and all of the infectious stool studies were normal. So there was concern with this chronic kind of soft, mushy bowel movements of like, C. diff, Giardia, oviparasites, all those types of things. Those were all ordered and were normal. In addition, her CRP was 0.08, which is normal. The normal limit of that is less than 0.1. Then they moved on and did a 24-hour fecal fat test, which, just as a side note, is kind of a hard thing to do for a patient. So they have to collect their stools for a total of a 24-hour period. And they also have to adhere to a very particular diet and record how many grams of fat they eat for 3 days in a row leading up to when they're going to do this collection. Because the way that the fecal fat tests are run is it's a percentage of the fat that's detected in the stools compared to what the patient ate. So essentially what was taken in, what is put out. So we're testing for malabsorption with that. So her fecal fat was very high. I won't go into the details because it gets into the weeds, but it was very high. So based on that, a colonoscopy was performed, and the colon itself was unremarkable, was normal. But when they got to the terminal ileum, there were some non-specific erosions, and the biopsy of those erosions showed a non-specific enteritis, which is just the doctor word for some inflammation in the colon, or in the small bowel. So given that extra information, that's kind of some obscure data there. I'm trying to remember who we left on. I think we're on Anne, maybe. If not, we'll go with it. What do you think are some options for some next steps? So, this colonoscopy and this biopsy didn't give us any clear answers, but there's something there. So anything that comes to mind, anything that you've seen as far as further options that maybe the GI doctors would pursue?
Well, I guess like with the idea that this terminal ileitis, I'm leaning towards kind of a Crohn's picture with this large stool volume multiple times. I cannot remember off the top of my head what you'd want to do as far as like testing for them. Yeah.
Totally, that's a great thought. I know that's drilled in pretty good in med school is terminal ileum equals Crohn's. That's definitely not always the case, but that definitely always has to go through your mind. Jacob and Rachel, any other thoughts, ideas? This is kind of a specialized thing, so I don't really expect you to have any tips on this, but any ideas?
Yeah, I mean, because her fecal fat is very high in the context of also having multiple erosions in the terminal ileum and large bowel movements multiple times a day, I'm worried about a malabsorption picture So I'd probably want to get some extra like vitamins and stuff, especially her fat soluble vitamins. So like A, D, E, and K. I guess you can measure those. I've really only seen A measured in any case I've been involved in, but make sure that she's getting the nutrition that she needs, especially in the context also of her BMI. Like if she's reporting that she's eating, then the reason she's probably is because of malnourishment. So definitely want to check on those things.
I don't have anything else to add.
Perfect. Rachel, thank you so much for bringing that up. I think as physicians, it can be really easy for us to get super wrapped up in like the diagnosis and this like problem that's before us. We're trying to solve the jigsaw puzzle, that we can forget that the person in front of us is a human that has needs right now. And so if our patient is being malnourished, it might take some weeks, sometimes especially outpatient, for us to get to the final diagnosis. But in the meantime, that's a person that needs medical treatment. So right on point. Super, super grateful that you thought of that, because a lot of doctors will just kind of pass over that unintentionally. So great thoughts on that. So I will so there are a couple different alternative options for kind of small bowel visualization that are a bit more nuanced and are pretty limited to the GI specialty. So obviously, we know that imaging of the small bowel can be pretty tough because we can't really go much past the ileum from the colon side, and we can't much go past the duodenum from the top due to risk for perforation. But a couple different workarounds for that. You can do imaging. So there are particular protocols for both CT and MRI. They're called CTE or MRE. So CT enteroscopy, enterography, and MR enterography. So quite a mouthful. So those are options. Some other options are something called a push endoscopy, which is basically where they take like an EGD camera similarly. And so it's this stick, and then they have kind of balloons that inflate on both sides. And you can think of it as like them caterpillaring their way through the small bowel using these balloons to protect it from perforation. So that's sometimes something that they'll do. And then another option that's becoming very, very popular and more used is the pill cam or the video capsule endoscopy, which is quite literally just a pill that's about the size of like your typical multivitamin or fish oil pill. That's actually a camera. And it takes, some doctors want a bowel prep, like a minimal one. Some doctors just want you to be on clear liquids the day before. And you swallow this little camera, and it can take anywhere from 8 hours to 12 hours to go through the GI tract. And it takes pictures the whole way through and sends the pictures to a little device that records it. And then someone will watch that and go through it and then record what they saw. So it's a way to see the entire small bowel. It's not perfectly sensitive, but it's a way to see the small bowel in a way that we can't really see otherwise. So those are some options. With this girl, the diagnosis was made using first imaging and then to confirm a capsule endoscopy. So I'm going to say that, and I'm going to ask you guys to put your money down. If you had to choose a diagnosis right now, what would you say you're putting your bets on? We'll start with Anne, and then we'll say Jacob and Rachel.
I guess for me right now, I'm still going to lean towards Crohn's.
Jacob, any thoughts?
No, not really.
That's great. I love it. It's perfectly fine. Rachel?
Oh, I'm trying to think back to that GI block. Yeah, I don't know. I guess we already looked at there wasn't any colon and rectal involvement, so I can't just go with the flip and say ulcerative colitis. Oh, maybe I'll do something crazy and I don't know, maybe some infiltrative disorder, some sort of rheumatologic diagnosis, like eosinophilic something or other. I don't know.
Fancy. I love it. When you're at an academic medical center, you can see the weirdest things, and it never hurts to guess. It's definitely more of an academic point to ask for a diagnosis right now because, even the GI docs didn't know what was going on. So thanks for stepping on a limb with me there, guys. So a CT enterography was done, which did show luminal narrowing and hyperenhancement or inflammation within the ileal small bowel in the left lower quadrant. Based on that, a capsule endoscopy was done, which came to the final diagnosis by findings of some erythema, erosions, ulcerations, and scars in 3 separate locations throughout the small bowel, which was consistent with a diagnosis of small bowel Crohn's disease. So Anne hit the nail on the head there, but we're not done because our patient needs treatment. So one thing I did want to note out was that the CRP, if you guys remember, the CRP was normal. And yet we have these fairly significant inflammation in the colon. And that's actually somewhat of a misconception, especially in small bowel Crohn's disease. The CRP can be flat out normal. And there's been a lot of really interesting studies that have looked at that. And they've found everything from some genetic correlations to some other kind of proposed just pathophysiological explanations, showing that especially the small bowel inflammation of Crohn's oftentimes will have a false negative CRP, which gives some problems because we use CRP a lot of times to trace kind of disease activity and as an initial diagnostic marker. So just something kind of to note for clinical pearls is not to rule out anything really based on one lab test, but in particular, any sort of Crohn's can't be ruled out with a negative CRP. So we have a diagnosis. You guys did an awesome job of working through kind of the pathway of getting here. So any thoughts on what initial treatment might be? You can throw out a couple options. What are some thoughts? Just kind of what's the first thing that comes to your mind for initial treatment of a new diagnosis of Crohn's? Let's go backwards again. So Rachel, we'll start with you.
Yeah, I mean, probably initially don't want her to be on them forever just because she's so young, but give her a course of steroids just to kind of get rid of the initial inflammation and then transition to a more like chronic treatment.
Yeah, for sure. Jacob, would you have any hesitation with giving her steroids?
I don't think so, but maybe I should.
No, don't doubt yourself. Steroids would be a great initial treatment. So for any sort of moderate or severe, especially active Crohn's disease, Rachel and Jacob, you guys are on the ball. Steroids are a wonderful treatment. Oftentimes we can be kind of scared of steroids from all the teaching that we get about the long-term side effects, but they are wonderful treatments for initial control of severe inflammatory disorders. So there are a couple different options for steroids for Crohn's. You can use budesonide, primarily for low risk and mildly active Crohn's. And budesonide, we typically think of as an inhaled steroid for asthma, but there's a particular formulation of it that's actually like an enteric coated pill so that it doesn't really start releasing until it gets kind of to the terminal small bowel and then to the colon. So it's really great for like isolated inflammatory disorders of those parts of the bowel because it's pretty minimal systemic absorption and it just releases down in those areas. So depending on what type of Crohn's you have, that's an option. But for more severe or more diffuse Crohn's, our good old faithful prednisone is kind of where we want to go. So the dosing for the prednisone typically starts out at about 40 milligrams daily for 7 days. And then there's a gradual taper down from there with about 1 to 2 months of treatment as kind of the initial induction phase is what they call it, for just getting control of the Crohn's in the moment until we can get on more long-term therapy, kind of like Rachel mentioned. In the past, some of the first-line treatments were like some 5-ASA and mesalamine and sulfasalazine. You guys might have remembered that from preclinicals. And those are still used sometimes, but they're really not first-line anymore. And they're more so used for ulcerative colitis and not so much for Crohn's. There's been quite a bit of evidence showing that those are not the best treatments for Crohn's. And so we really don't see that quite as much anymore. So Anne, seeing that dose of prednisone, so 40 milligrams daily for 7 days, does that strike you as kind of like a low, moderate, or high dose of steroids? And then would there be anything that you'd want to just kind of keep in the back of your head if you were like this girl's primary care physician to kind of just watch out for while she's on this kind of 1 to 2 month course of steroids?
It's probably a moderate dose is kind of my initial impression, but maybe considering like a GI prophylaxis for her as well, because I know it can give most patients I've seen, more so with high dose, we give them like omeprazole or some sort of PPI. But then since her BMI is pretty low, like just try and make sure to optimize her nutrition on the steroids. And then it can have some psych effects, so just knowing that, but I guess just being aware.
Yeah, those are great points, especially with a Crohn's patient. Like adding a PPI is a wonderful idea. There have been some recent studies connecting long-term PPIs with some issues, including like C. diff and colon cancers and diabetes and stuff, but that's like long-term. So in the short term, I love it. PPIs are a great thought. And yeah, the psych effects, some people tolerate steroids great, and some people, they affect them weird. So just warning her about that, I think is a super idea. Some other things to be aware of, and this oftentimes is more so in the hospital than outpatient, but especially starting steroids, you can get some high blood pressure and some high blood sugars. So you would just want to monitor the blood pressure, and really don't need to treat it per se unless it gets super high, like above 170, 180. But even, into the 130s, 140s, 150s is really okay for a short term in the hospital. We wouldn't want to overtreat something that is due to something that we know the cause. And then the blood sugars are interesting because it's actually primarily a postprandial blood sugar spike. And so with these patients, oftentimes we can just treat them with mealtime insulin. We don't need to give them like long-term basals like we would in our patients with diabetes, because the steroids actually cause postprandial spikes in the blood sugars. So you'll see that their fasting levels are actually normally just fine, just normal. And then it's just after they eat, their sugars just peak pretty high. And so we can just go ahead and plan on giving them a set dose of like an insulin aspart, like from like a 5-unit dose or something like that, just with their meals to help control that spike is normally pretty effective. And then as they taper down, they won't need that insulin as much. Other things just to keep in mind is that they will have a leukocytosis. So as you are, if they're in the hospital, if you're getting daily labs, you will expect an increase in their white blood cell count. And that can be kind of confounding if there's some concerns for infections. But it's important to know that that is expected. And so that's normal. And so that's not a need to particularly initiate antibiotics or something like that if it's isolated. But you do have to take it into account, if they spike a fever, if they're having other signs of infection, that, it could be a confounding picture. So just something to keep in mind. That being said, another little pearl that I wanted to mention, does anyone know off the top of your head the indications for PJP prophylaxis on steroids? Because that's one of the things that we always have to be aware of when we have immunosuppressed patients, would be PJP prophylaxis. So Anne hit it on the head that this is kind of a moderate dose of steroids, kind of moderate to high, depending on what context you're in. So would we consider prophylaxing her for this? What do you think? Rachel, any initial thoughts?
I don't know if you'd be concerned of it with her kind of like malnutrition picture, that maybe her immune system wouldn't be completely up to par. So you'd want to at least be more cautious of it.
Are you sure you're just in your third year? Because that is like way advanced thinking. I love that. And this is something that you would look up every time. So most people are not going to be, most general physicians are probably not going to be prescribing this much prednisone enough to know off the top of their head, off the bat, necessarily what prednisone dose would require prophylaxis. So quick Google search, quick up-to-date search, super easy to find. Not something to waste your brain space trying to memorize little details like this. So the indications for PJP prophylaxis with prednisone, or for steroids in general, are at an equivalent dose of 20 milligrams or more of prednisone daily. So I say equal to the such, like if they were on dexamethasone or something like that, that's not prednisone, you can do the equivalent dose to it. So 20 milligrams daily for greater than or equal to a month. And then depending on what source you look at, some sources say you also need an additional immunosuppressing condition on top of that to qualify for prophylaxis. And some just say, greater than 20 for a month would indicate for it. And I think, Rachel, your point of her being malnourished as a potential immunocompromising condition is an amazing point, and I think would be something that a lot of people would look over. But just like we talk about how having diabetes can be immunosuppressing, having other chronic conditions can be immunosuppressing, and being malnourished can be very immunosuppressing. So I think that's a wonderful thought. And so with our patient here, she would not probably qualify for PJP prophylaxis, assuming that hopefully we're able to get her off of these steroids fairly quickly here. But in the case that maybe, she has really refractory disease and it's just very difficult to control, at some point she might qualify. So that's just something to really keep in mind and always kind of have on the back burner whenever we have patients on medications like this, especially steroids. Next kind of information from our patient. Rachel mentioned earlier about doing like some vitamin tests. And so working up for a malnourishment in a setting like this with chronic diarrhea, I think is critically important. So some labs that I have on her, an iron panel was done and her iron level was 37 with the normal range being 50 to 180. Her percent saturation was 12% with the normal range being 15 to 50. And her ferritin level was 10 with the normal range being 20 to 200. In addition to the iron panel, her B12 was measured and it came back at 543 with the normal being above 400. And the vitamin D level, D25OH, came back as 22 with the normal range being 25 to 80. So Anne, can you take a stab at interpreting the iron panel?
Yeah, so she has, I don't think it's necessarily anemia of chronic disease because it's not a high like stored iron, but I think it's just because of lack of nutrition is kind of what it is, my interpretation. Yeah, so I think supplementing for her would be beneficial.
And off the top of your head, how would you go about supplementing? Have you heard anything about, there's been some controversy about like oral iron supplementation. Have you heard anything about that?
I have not heard anything.
Awesome. Okay, so there is some controversy about the oral absorption of iron. So some of the kind of typical dosing regimens would be like oral iron once or even twice a day to try and maximize absorption. But if you think back to our preclinical days with the hematology stuff, when you have, when you take in iron, there's the whole process. I won't go into the whole pathophys, but the whole process of your body binding to that iron and absorbing it into the system. However, when you have a lot of iron intake, the feedback loops tend to turn that off. And so there's actually been some studies showing that when you take in iron consistently, especially multiple times a day, like in a supplement form, you really don't actually absorb it. You're kind of shooting yourself in the foot by taking it that often. You don't absorb it very well. And then add insult to injury, we have a malabsorptive disease like Crohn's that impairs absorption to begin with. And so some oral repletion may not work very well. Depending on your patient, it might definitely be worth a trial. But particularly in Crohn's patients, oftentimes the GI docs will go straight to IV iron. And IV iron used to be kind of a big no risk for anaphylaxis type of a thing. But that was back when they used a formulation called iron dextran that isn't even on the market anymore. And so it's kind of a misconception that IV iron is a big anaphylactic risk. In fact, we have multiple different formulations now that are very safe, and many of them don't even require test doses anymore, which used to be a requirement to make sure that you wouldn't have anaphylaxis to it. But that's not even enough of a risk now to require that. So there's a couple different IV iron formulations available. Some require, there's one that requires just 1 dose, there's one that require 2 or 3 doses, and there's some that require up to 5 doses. And it really just kind of depends on physician preference on kind of which one you would order. And then also thinking about what's practical for your patient. So if there's someone that lives a while away, maybe doing the one that requires only 1 or 2 doses would be better versus if there's someone that, lives pretty close or they'll be coming in for other things anyway, doing the other ones that, may be a little more cost effective for them, but would require like 5 to 6 doses might be okay. So just some things to think about. So she was given IV iron. Specifically, she was given, iron sucrose, which the brand name is Venifer. And that comes in 200 to 300 milligram doses, and she got 5 doses over the course of a few weeks. She was also given vitamin D supplementation, 2,000 units daily. And interestingly, her B12 was normal, which typically we associate that with Crohn's because of the terminal ileum. But as we saw earlier, her terminal ileum wasn't terribly involved. So she was not given supplementation of the B12. So given all of this, Crohn's disease can be a pretty heavy diagnosis. So Rachel, any thoughts on kind of what type of counseling you would give her, especially if she goes to the Dr. Google and sees that a lot of Crohn's patients end up having surgery? And, what if she asks you, am I going to have surgery? Am I going to have an ileostomy? What is my life going to look like? Any particular ways that you would approach answering that question or talking her through this initial kind of heavy diagnosis?
Yeah, I'd probably start with just you have to be realistic and you have to be honest with your patients. So just saying, the numbers, the specifics, like how long the people that are getting those types of procedures and having that type of management have had their disease, because that's, I feel like, a more long-term thing when somebody's been having their disease for years and years. And then also probably working with my dietitian colleagues to get her in just so she can understand what really makes her Crohn's flare up and just be bad symptom wise for her, as well as counseling on foods that are inflammatory and what works for her and her budget. A lot of those things are very expensive, but trying, to provide her resources and just information so she's not having to go to Google and can actually get it from someone who's been trained in this stuff. And then the other thing, if she does ever have to transfer to a more expensive medication like Remicade or Humira or something like that, just making sure that she has the social support, insurance, that sort of thing all set up so she's ready to go when that happens, because I wouldn't want to hit a patient with that type of bill. So yeah, that would probably be my biggest thing, is just kind of those colleagues and working with those people that can really help her the most.
I think everything that you just said will probably be what she remembers from all of this, because having such a heavy diagnosis put on you, a lot of this kind of medical objective information can go right over the patient's head. But someone really sitting down with them and talking through and acknowledging that this is a lot and that it's scary, and then connecting them with resources, using the different professions that we have around us, referring to our colleagues, and getting the patient kind of real life help. I love that you talked about what types of foods would cause disease flares, because ultimately that's what's going to matter for her. It's going to be, in her daily life, what's going to make things manageable and what's going to make things tough. She may not understand the inflammatory processes going on, but she understands, hey, I ate this and it makes me feel bad. So huge hit on the head for that. I love that so much. And that's something that it can be kind of easy for us as doctors and doctors in training to really kind of skip over. So big kudos to you for thinking of that up front. That's awesome. So the food recommendations for Crohn's disease, unfortunately, there's not kind of a quick and easy recipe for this, as far as what foods to avoid. There are some general things that tend to flare most people, but everyone's flares kind of are caused by different things. And so what may be really hard for one person might be totally fine for another person. But some common things that I would recommend to avoid for patients with Crohn's disease include a lot of caffeine. Any sort of very sugary foods can also be very triggering, or any very spicy foods. And then in particular, people with small bowel disease, any sort of really sharp or harsh or scraping food. So nuts can be really irritating, chips, that type of a thing that maybe if they're not chewed super well can cause some scraping and irritation of already irritated bowel, is something to think about. And then if they have any strictures, especially in their small bowel, especially early on, it's important to kind of talk to them about avoiding really tough meats, like really tough steak, and then larger pills, because they can actually cause partial or even full obstructions by eating things that can't be broken down enough to get through those strictures. So those are just really important things to keep in mind to kind of advise them on, that they may not really realize that, hey, your bowel gets really small in this one area and we need to be careful about that. So Rachel kind of foreshadowed a little bit, but Jacob, any particular more long-term, newer, fancy special medications that you're aware of to be able to treat something like Crohn's?
I don't think I know any now.
And what about you? Anything come to mind?
Yeah, the TNF alpha inhibitors. So I think the infliximab and then adalimumab. I don't know the brand names like Rachel does, but but yeah, and I guess the one thing I've always remembered with those is I think they have to get tested for TB before starting because that can be a big issue.
Absolutely. You are way ahead of the game. I love it. Definitely testing for TB. Jacob, anything else that comes to mind about infections that maybe we'd want to check on before starting someone on an immunosuppressant?
I should definitely have an answer for this, but
No such thing. No shoulds. Just thoughts. No should.
No, I'm not sure.
Okay, so some big ones that we want to rule out. The TB is an obvious one. And that's a big one because with the TNF inhibitors, TNF is the body's major defense against TB. So if we knock that out with a TNF inhibitor, if they have like latent TB, we can cause it to reactivate. So that's why we always have to test with that. There's a couple different options for that. You can use the QuantiFERON Gold is the brand name test for one, or the T-Spot is what they use at KU now. Either of those will work just fine. And then we also want to test for hepatitis B and hepatitis C. Those are things to make sure that A, they don't have the active virus. If they do, then that needs to be treated. Or B, if they're not immune to hepatitis B, then we need to immunize them to hepatitis B before they get the TNF alpha inhibitor. And then the next thing to think about is immunizations. Rachel, what immunizations come to mind as maybe things that we'd want to make sure of on top of the hepatitis B that we already mentioned?
Yeah. I mean, any of like our live immunizations, just because you maybe should avoid those if you're going to be severely immunosuppressed. Specifically hepatitis B. I mean, making sure she's just up to date on all of her vaccinations would be great. Using our vaccine schedule. If there's an app, that's really good. That's what I'd probably look at.
Yeah, for sure. That's always super important. Always make sure to get your annual flu vaccine. Got to get that flu. And then some other kind of niche ones that we may not always think about. One is the meningococcal B vaccine. There actually is an indication for getting that if you're going to start a TNF inhibitor. So that's a newer vaccine. So it's on top of the meningococcal that we all get as kiddos in school. Meningococcal B was recently approved. There's a couple different brand names for them, including Trememba and Bexsero are the two approved in the United States. So those can be kind of tough to find because they're not officially on any of the recommended vaccine schedules. So not all pharmacies carry them. So it might be kind of a task for the patients to be able to get them, but they are available. They just have to call pharmacies and have them ordered. And then the other thing is that starting an immunomodulator like this would be an indication for the Pneumovax vaccine or the PPSV23. So if that's the case, if you've done your family med rotation, you'll remember that you would start with the PCV13, which is the one that we get as kids. So if she needs that, if she's not up to date on that, then we'd give that first and then wait 8 weeks and then give the PPSV23, which is kind of what we think about as the adult pneumonia vaccine. And then if she's already had her PCV13, then great, you can just give the 23 valent. And then every 5 to 10 years, if she's still on this therapy, you'd want to consider revaccinating with the 23 valent vaccine. So all that said, yes, you guys mentioned the infliximab, which is Remicade is the brand name. And then there's also biosimilars available. So there's also some other brand names. And then adalimumab, which is Humira, is the original brand name. But then there's also biosimilars of that one, which those biosimilars were recently approved and they're much cheaper. They're still expensive, but they're much cheaper. So we have multiple options for our patients. And then it's also important to know that a lot of these drug companies for the brand name drugs have prescription assistance programs. So these patients that need these medications, there's definitely all sorts of programs that they can apply for and potentially qualify to get reduced, if not free, access to some of these really important and potentially life-saving medications. Because we do have great data showing that these TNF inhibitors are extremely effective and potentially can help our patients avoid some of the more scary long-term outcomes that they might find on Google, such as needing, a lot of your bowel resected and that type of thing. So important to jump on these effective therapies early. And then there's also more advanced therapies as well. If the TNF inhibitors don't work, there's anti-interleukin 23, which I'm not even going to try and pronounce the name, but the brand name is Stelara. You might have heard of that. And then there's an anti-alpha 4 beta 7 integrin, which is very complicated, but the brand name is Entyvio. You might have heard of Entyvio. But those are all monoclonal antibodies that have been approved for Crohn's disease. So even if the TNF inhibitors don't work, or if they stop working, there are more options to get our patients and keep them under control and prevent some of those long-term outcomes. So that being said, that is kind of the conclusion of our case. Our patient was started on a TNF inhibitor in addition to azathioprine, which are one of the more older immunomodulators, which is sometimes used in combination with the TNF inhibitors. And she was able to get into remission. And to this date is on just the TNF inhibitor. She was able to get off of the azathioprine and is in remission on infliximab. So she'll follow up with GI probably for the rest of her life, but hopefully keep her disease under control with some of our more advanced medications. So with that, any final thoughts? Or just like kind of one big takeaway from each of our discussants? I love just kind of what's something that stuck out to you or something that you'll take away from this. Anne, we'll start with you.
Yeah, I think a big thing for me with this case is it started out as something like so vague and just like something you kind of fixed in the meantime, but I think it's really important to remember to get that follow-up and help figure out what was the cause and to follow through with that for these patients.
I love it. That's amazing point. Nothing to add to that. Jacob, any takeaway from you?
I think trying to just keep in mind some of the secondary effects of some of the things that you see in patients. So like in this case, the malabsorption and how that can affect vitamins.
I love it. Rachel?
Yeah, just that abdominal pain is a huge differential. And so I think it's really easy to anchor on just like the first thing that comes to your head when you think abdominal pain. So trying not to do that and just slowly mark things off of your huge differential. Abdominal pain is like my least favorite chief complaint because it's just so overwhelming.
So overwhelming, but yet your brains are so great and we can parcel it down. Very nice. Alrighty. Kelsey, any particular big teaching points or take-home points that you wanted to mention before we sign off?
Yeah, and one that was a big one for me is CRP can be normal in IBD. I think a lot of times we see that normal CRP and we're like, nope, nothing rheumatologic's going on. We're just going to move on. So that is definitely a big one. Risk associated with steroids, important to keep in mind the high blood pressure, high blood sugar, the leukocytosis, and the infection risk. I know that's a common issue, especially in the inpatient settings. If a patient's getting steroids in the setting of a possible infection, and do we treat them periodically with antibiotics or do we just accept that maybe it was steroids? So that's always kind of a difficult game, especially inpatient. And then otherwise, some of the controversy about oral iron supplementation, might need to go straight to IV sometimes. And then just kind of the discussion we had, and I won't reread all of the things about them, but just the discussion of what the biologic options are, and just kind of keep in mind that they'll be immunosuppressing people. So be sure that you have ruled out any infections they're going to be at high risk of because of their biologics, and then to immunize them against diseases as well.
Awesome. Those are all great high points. All right. Well, thank you guys so much. Thank you for being our willing participants on our inaugural med student only discussion. You guys did amazing. Just really appreciate you guys being willing to just kind of put yourself out there, take a risk, give us your thoughts. This was an amazing discussion. I'm very impressed. You guys are definitely way kind of above your pay grade here, being first year and third year medical students. So really appreciate y'all being on. And with that, we will sign off. Have a great night, and we'll see y'all next time.